Good afternoon. See you all reaching for your glass of water, huh? Okay, we're going to talk about stones. I showed you my official title on the previous slide, but on this slide is the title that you need to remember, okay? If the only thing you remember from my talk is the title of this slide, I'll be very happy. And that's because I've seen patients that have had 2, 10, or 50 kidney stones and nobody ever told them that. Okay, so our job as nephrologists is really important to make sure that we remind our urologic colleagues that we actually do know how to prevent kidney stones. So now we're going to go through some of the details. So we want to do this case-based, so of course I'm not going to be able to cover everything, but these are all patients that I've seen. Hopefully this is very practical information. So the first one is Mr. G.O., 52-year-old, passes a stone every 2 months. Who thinks that's okay? Okay, well, apparently somebody did because nobody had ever told them that the way that stones can be prevented. His past medical history was notable for chronic diarrhea and meds. He was taking what's listed there, including allopurinol. So his evaluation, his initial serum bicarb was 26, his uric acid on allopurinol was 5.5, and he had a KUB that didn't show any stones. So of course, urology gets a renal consult, and the questions that we want to know first are the stone type, okay, the evaluation, and then the treatment. So, when I see patients in clinic and they tell me they have had kidney stone, I ask, well, what type of stone? And they always say a kidney stone, as if I didn't hear them the first time, okay? But you really want to know what that stone's made out of, okay? Because while it may not affect the evaluation initially, it is going to affect your decision. So you need to ask your patients nicely to retrieve the stone, which is the way of nicely saying, please stick your hand in the toilet and bring me that little rock that you passed, okay? Of course, if they pass it on the turnpike, I don't ask them to do that, but we do want to know what the stone's made out of. Hopefully you're all looking actually at the urine sediment when you see these patients. For those that don't have a stone type, you may see crystals in the urine that may be diagnostic as well. Okay, so let's go back to Mr. O, most likely stone type. I don't think that we're doing this electronically, right? Great, okay. I didn't want to wait. So you can either shout out, calcium oxalate. Okay, you should always vote calcium oxalate because that's the most common type of stone, okay? But there's some things that are a little different. This guy was passing a stone every 2 months. It's rare for someone to be forming calcium oxalate stones at that rate, okay? But actually cysteine, uric acid, and calcium phosphate all can form at that rate, okay? It's on allopurinol. Does that change your mind at all? Okay, well, lots of people get put on allopurinol for uric acid stones, but actually the most important thing for preventing uric acid stones is the urine pH, not the amount of uric acid. So people are often mistreated, okay? And allopurinol obviously doesn't work for cysteine, or maybe he had gout. I didn't have a complete history, but what if I showed you what his urine sediment looked like? Would that change your mind? Okay, so these are classic uric acid crystals, okay? You'll often hear the term pleomorphic. These crystals all came from the same person at the same time, okay? They're actually quite beautiful. These are kind of the more classic ones, but even these are not the shards from the cover slip, which we often see, but in fact, these are uric acid, just under usual microscope without polarization, though they do beautifully polarize. Okay, so this person did form uric acid stones. When you're passing them every 2 months, you should be able to get a stone for analysis. But things that suggest uric acid stone formation, again, are very rapid stone formation. And when we say rapid in the stone world, every few months would be rapid. Chronic diarrhea may often lead to a metabolic acidosis, which will lead to a more acidic urine. And again, the most important piece, a risk factor for uric acid stones is persistently acid urine. The fact that the KUB didn't show any stones. If you took all comers of stones and you didn't see a stone on KUB when they had classic renal colic, you still should vote for calcium oxalate. And that's because it's much more likely to have a calcium oxalate stone and that it's small enough that it's not seen on KUB. I've been trying to avoid the term radiolucent because uric acid stones are seen by CT, which obviously is radiography as well, so even without contrast. So KUB, not seeing a stone on KUB doesn't necessarily mean that it's uric acid. Okay, and this guy was also very proud about all the stones that he could pass and sent me this picture. So, okay, so if we talk about types of stone, first-time stone formers, again, as we mentioned, calcium oxalate about 3/4 of them. Calcium phosphate is the next time, and really important. Many times patients say I had a calcium stone, and of course the stones aren't pure calcium, they're calcium salts, so either calcium oxide or calcium phosphate. Uric acid is a slightly smaller slice of the pie, and then struvite, cysteine, and drugs are even smaller. So I'm just going to briefly review main types of stones and main causes. This is not meant to be an exhaustive list at all, but clinically, this is often enough that all you need to know to actually make a big difference in reducing recurrence rates. So calcium oxalate stones, low urine volume. This actually applies to all stone types. The lower the urine volume, the more concentrated the lithogenic factors are, the more likely it is that they will form more stones. High calcium, and I don't use the term hypercalciuria. That's a dichotomous term, okay? And these things are continuous. So higher calcium is going to be a risk factor. It doesn't have to reach some magic threshold before it becomes an important factor. Higher urine oxalate is a risk factor for calcium oxalate stones, and low urine citrate. I do want to point out, and I just saw a woman last Friday who had uric acid stones that was put on a low oxalate diet, okay? And there really isn't any justification for putting people that form uric acid stones on low oxalate diets. So please measure some of these things before you start giving advice. Again, low citrate. Citrate's a natural inhibitor of both calcium oxalate and calcium phosphate stones, so we actually want the citrate to be higher. So for calcium phosphate stones, again, low urine volume, more alkaline urine. So urine pH is important for some stone types, but not for all stone types. So calcium oxalate is pH insensitive in the physiologic range of 5 to 8. Calcium phosphate stones are more likely to form when the urine's more alkaline. And when we say alkaline urine, we usually mean about 6.5 or higher. I'd mentioned before about uric acid being persistently acidic, and that's 5.5 or lower. But calcium phosphate stone risk factors also include higher calcium, lower volume, as I mentioned, and lower citrate. And we'll come back to that in a little bit. Uric acid, the most important, is persistently acid urine. The amount of uric acid may matter in some people, but not nearly as much as the urine pH. And it's really important to focus on that because that's the best way to prevent them. Cysteine is an autosomal recessive disorder. There's nothing that anybody can eat or drink to form cysteine stones. So if you see cysteine come back in the stone composition, or if you see the cysteine crystals, you'll know for sure that they have this autosomal recessive disorder. And struvite, this crystal type goes by a bunch of different names, infection stones, magnesium ammonium phosphate, triple phosphate, but these stones only form when there's a urease-producing bacterium in the upper tract, okay? So if the stone composition comes back including struvite, you really want to make sure that the person has been treated appropriately for an upper tract infection. Individuals that have persistently cystitis won't form struvite stones unless the bacteria makes its way up. And the most common urease-producing bacterium is Proteus. Okay, I want to give you some sense of incidence and prevalence of stone disease, okay? Incidence is how likely is someone going to form their first stone if they've never formed a stone before. And I'm not advocating primary prevention of stone disease. There's way too many other things that we need to try to prevent from primarily prevent. But once somebody's had a stone, I can assure you they don't want to have a second stone. But let me give you some information about incidence, okay? So for men, these are 3 large cohorts that I work with involving several 100,000 participants across the US. We've been following them for decades for all sorts of conditions, including kidney stones. But for men between the ages of 40 and 60, if you've never had a stone before, your risk is about 3 per 1,000 per year. It goes down with age, but still a man 75 or older can present with his first stone. In younger women, it's 2.5 per 1,000, and in older women, it's about 1.5 per 1,000. Okay, and the reason that that's important is sometimes people say, well, what should I do to prevent getting my first kidney stone? And I usually say nothing, okay? If they really want to try to do something, they can drink a little bit more, but we don't want to evaluate people to prevent their first kidney stone, okay? But once they've had a stone, we really want to know what the likelihood of recurrence is, because that is going to influence how aggressive we are and how likely it is that the patient's going to adhere to our recommendations. And despite the fact of me telling you how common stone disease is, again, 1 in 5 men, 1 in 10 women will form a stone at some point. I'm a little embarrassed to show you the size of the randomized trials that have been published. There is a larger one that's ongoing now, but still going to be in the hundreds, certainly not the thousands. So looking at the randomized trials in the control arm and then also observational studies, it looks like on average the recurrence rate is about 5% per year. Okay, but that's on average. And there are ways to identify those that are much higher risk, and we're going to talk about some of those risk factors actually right now, okay? Didn't know the slide was here. Okay, so for calcium oxalate stones, the higher the urine calcium, the higher the urine oxalate, the higher the risk. For the higher the citrate and the higher the volume, the lower the risk, okay? But again, don't just think about this dichotomously. Don't look at your lab's reference ranges and say, oh, everything's normal within the reference range. My institution, the reference range for urinary calcium is 50 to 400. Okay, it's completely unhelpful because your risk goes up continuously. And if I said, well, I'm only going to treat people that are, quote, abnormal, I'd be missing a huge number of people, okay? I'll talk a little bit more about the details, but really this is continuous. These are continuous variables, so anything we can do to either get the urine calcium or oxalate down or the urine citrate and volume up will all make a big difference in reducing stone recurrence. I don't want you to remember anything on this slide, okay? But I'm showing you because lots of times there are these definitions out there, and these are the more traditional ones. Hypercalciuria defined, men are allowed to have up to 300 milligrams of calcium per day in their urine, women 250. So I hope one question comes right to mind, well, why are men allowed to have higher urine calcium than women? And I'll show you shortly that there's no justification for that. Please do not use weight-based definitions if you're an adult nephrologist. That means if you gain weight, you're allowed to have more calcium in your urine. Again, it doesn't make any sense at all from a stone perspective. Hyperoxaluria definition made up, hyperuricosuric definition made up. I'll show you some data a little bit more later on, but again, the idea here is that these are continuous variables and you don't want to just use thresholds to make clinical decisions. So let's go back to Mr. O. You know that he has uric acid stones. He performed 2 24-hour urines, and here are the results. So this is total volume, calcium, oxalate, citrate, uric acid, creatinine, sodium, and pH. And of course, the first thing you're going to look at is the urine creatinine, right? Before you start looking at any of the other numbers, you want to see how consistent the values are between the two collections. Lots of people say, oh, I can determine whether it's a complete collection or not. Yeah, maybe you're okay at that, but I bet most of you had no idea what your 24-hour urine creatinine actually is, okay? And there's a lot of variability depending on age, sex, race, and actually what people are eating, muscle mass. There's other things, so it's actually hard to predict. So I use the creatinine not to just get some idea of whether it's complete or not, but actually look at consistency because the same individual should be more or less consistent. His urine creatinines are way more than 20% different, which is usually the acceptable range of what I would use. And so then the question is, well, how do you decide which one of these is correct? Do a third one. Yes, that is the right answer, okay? And the reason you have to do a third one is because none of these other things are produced in constant amounts. So the amount you drink does not tell you whether it's a complete collection or not, okay? I've seen this over and over again where people say, oh, there's lots of urine in there, so it must be a complete collection, or it's very low, or it's an incomplete collection. And actually, the main determinant of urine volume is how much you drink, right? Okay, so remember that. All these others can be affected, so again, it needs to have a third one. Okay, so then next steps. When a patient's forming that many stones, you want to get some sense of what their stone burden is, okay? And while ultrasound doesn't have any radiation, it's okay, and I use it quite a bit once I know what their stone burden is. In this case, we definitely want to do a helical or spiral CT without contrast. Again, even though it's uric acid, you still can see the stones on CT. You want to quantify stone burden because what we don't know is, does he have 50 stones that he's just passing every 2 months? Or does he have 1 or even no stones and he's actually forming stones? And I want to separate stone formation from stone passage because unfortunately several people in this room have a kidney stone right now in their kidney. Hope it stays there forever, but at some point it's going to pass. But if it passes tonight, that does not mean that my talk caused that stone to form and pass, okay? People get confused about how long it takes stones to form. We actually don't know what causes stones to move and become symptomatic. But it isn't just what happened recently for most stones. It's actually, we have no idea when the stone formed. We always want to look at old imaging studies if we have them to get some idea if someone's an active stone former, not just a stone passer. We want to repeat the 24-hour urine, as somebody already suggested, so that we are sure about what his true baseline is. And again, alkalization of the urine is the most important risk factor for uric acid stones. The best way to alkalize the urine is using either a citrate salt or bicarbonate salt. Almost always we don't want to use a sodium-based salt, so we'll use a potassium-based salt. I really want to emphasize potassium bicarbonate is just as effective as potassium citrate. You've probably heard more about potassium citrate But unfortunately, the company that makes the generic also is the company that makes the brand name. And so there's only a single supplier and they've jacked up the price. Potassium bicarbonate is relatively inexpensive. It comes in an effervescent tablet. I ask my patients to buy pH tape. You can buy it on some national warehouses, and it comes out like Scotch tape, and they just rip off a little bit. You tell them to dip it in their stream. Again, not dip it in the toilet, dip it in the stream, and then just keep a diary at different times of day of what the urine pH is, and then you can adjust the dose accordingly. But if you can keep the urine pH 6.5 or higher, not only will they not form any new stones, you may actually dissolve some of the existing stones. I'm sorry? Yeah, 6.5 or higher is ideal. Okay, since you asked, I'll show you this chart. On the vertical axis is the undissociated uric acid. That's what precipitates. So the higher the bar, the more likely these crystals will form. As you go from a low urine pH to a high urine pH, the likelihood of crystal formation is low. And here's the total uric acid in milligrams per liter. So some individuals, even with lots of uric acid in their urine, if you can keep the urine pH high enough, they will stay below this level of crystallization, okay? So again, the urine pH is the most important aspect. Okay, uric acid stones are really the most fun to take care of. If you can get we're very good at knowing how to alkalinize the urine. So if you can alkalinize the urine, you can actually stop new stone formation. Okay, it's probably the easiest one to do of all the types of stones. So Miss K is a 45-year-old recurrent stones. She's forming a stone every 8 to 10 months. Who thinks that's okay? Great, I'm glad to not see any hands, okay? She was told, oh yeah, come back, you're passing them all, it's no problem, you've only needed occasional procedures. Well, when I found out the occasional, she had extracorporeal lithotripsy 5 times, cystoscopy 6 times, and PCNL, or percutaneous nephrolithotomy, had to have a nephrostomy tube in, and the urologist went in because she had a gigantic stone in one of her kidneys. Otherwise healthy. So her 24-hour urine before she came to see me, urine volume was above my target for most stone formers of over 2 liters and preferably 2.5 liters per day. Urine calcium's in range, oxalate's in range, citrate was nice and high, though she's actually on potassium citrate. Okay, and the creatinine was appropriate for a woman her size. So most likely stone type. So of course you should always guess calcium oxalate. Okay, 8 to 10 months to form a stone is not unreasonable, but her urine chemistry's actually looked pretty good, so it'd be a little bit surprising. Her urine pH is 7.3. Is this a uric acid stone? Absolutely not. Okay, but it could be calcium phosphate, again, more likely to form in more alkaline urine. And then cystine's certainly possible, though it's quite rare. But what if I showed you her urine sediment? I don't know if you can see some of these things. Know what those are? Cystine, okay, so you can make the diagnosis of cystinuria simply by looking at the urine sediment. Here's a higher power of another field for her. So these are just the classic hexagonal crystals. So cystine's an autosomal recessive disorder, okay, and they actually, the issue is that these individuals don't reabsorb several amino acids, but the only one that really matters is cysteine because it's very poorly soluble. So as far as medications, she'd been put on potassium citrate. Cysteine is more soluble at higher urine pH, but it's rarely enough to keep the cysteine in solution. She'd been tried on penicillamine in the past, but developed a rash, and so had not been treated for quite some years with medication, but had been treated multiple times by the urologist. So her CT report showed that her right kidney is normal, meaning no stones were in there, and the left kidney had a 4 millimeter, 2 millimeter, 9 millimeter stone, and this was done at the time that she was symptomatic, and there was a 4 millimeter stone at the left ureteral vesicle junction, a very common place for a stone to get stuck, okay? Does she only have cystinuria in her left kidney? Why is she not forming stones in her right kidney? Yeah, I don't know. I'm sure she has cystinuria in both, okay? But you will see that some patients are sided, okay? Whether it's cysteine or calcium oxalate, and there must be some other anatomic abnormality that's predisposing them just on that side, but I'm sure that she's got cystinuria on both sides. Okay, so what I didn't show you in that initial 24-hour urine is that they also had the cysteine excretion, which was extremely high. People without cystinuria have 60 milligrams per day or less. Okay, and the concentration of cysteine is really important. Hers was over 800 milligrams per liter. So why is that important? Well, the solubility of cysteine is 250 milligrams per liter. Okay, so she's got close to 1,900 milligrams. The solubility is 250. So the urologist was encouraging her to drink enough to keep things in solution. So how much urine would she have to make a day? Okay, yeah, you start doing the calculations, it's over 7 liters per day, okay? That just is not practical for anybody, okay? Of course, you want to get it as high as possible to reduce the concentration, but these individuals often require another drug. She was allergic to penicillamine, so tiopronin is usually the first drug of choice. It's the trade name is Thiola, and most patients need about 900 milligrams per day. It needs to be taken TID just because of the excretion pattern. It needs to be in the urine at the same time as the cysteine. It does not change the amount of cysteine that's coming out. It covalently binds to the cysteine and changes its solubility. Okay, so we don't measure follow-up cysteine levels because there's no reason to do that. But as far as guiding the dose, we're guessing a little bit, and if you look at the product information for tiopronin, it'll help guide you a little bit on how much you need to give. But also you want to continue the alkalization because, again, that helps. So you want them to try to drink as much as they can, alkalize their urine, but almost always they're going to require tiopronin. So 6 months later, after taking her medication as prescribed, and she was very reliable, she calls me with left renal colic, and she is unhappy, okay? Because she said clearly the medication was not working, so she stopped it. Is she correct? The patient's not right? Okay, so why isn't she correct? Okay, yeah, because the CT, okay? She had 3 pre-existing stones. Sometimes you can dissolve cysteine stones, but not always. It's really important, not for your cysteine, just your cysteine stone forms, but for all your patients, that you go over that CT report with them and you let them know how many residual stones they have. Most people do not tell, most of the healthcare people aren't telling the patients when they come in the emergency room about all the other stones that they have. Everybody's focused on the ureteral stone, which is causing the symptoms. The patients are not going to be happy when you tell them this. Okay, but it's really important you tell them this because you don't want them stopping their medication if in fact that's the right treatment, or changing their dietary habits after you've put them on a good protocol. So this isn't her picture, but from another patient. Again, from the emergency room, everybody's focused on the distal ureteral stone, but really important that you tell the patient about this other one up in the kidney. Okay, so cysteine stones, if you get individuals on the right dose, and she's an example, she has not had a recurrent cysteine stone. And I don't want to make it sound like none of my patients get recurrent stones, okay? They do, but for cysteine and uric acid, if you are able to get them on the right regimen and they're able to tolerate the medication, you should be able to stop new stone formation. Okay, now we'll get to the harder stones, more difficult, not physically harder. So Miss JB, 35-year-old nurse with recurrent stones, okay? Are medical people more likely to get kidney stones? Why is that? Why don't they drink? They don't like to pee. Okay. Why don't we like to pee? Well, we learned a long time ago that it's a little inconvenient, and we probably learned either as a third-year medical student, maybe as an intern, that we don't have time to pee, and the best way to learn not to pee is not to drink, okay? The more concentrated, the less you drink, the less your urine volume, the more concentrated. So yes, medical people are not inherently at higher risk, but behaviorally are at higher risk. So she presented 5 years before she saw me with renal colic and bilateral stones. How many stones does she have? We don't know, okay? We know she has at least 2, okay? But the radiologist will often report this. I bet you go back and you see this all the time, bilateral stones. Not helpful radiology report, okay? You need to ask your radiologist to say, I want to know how many stones there are and I want to know how big they are, because you're going to implement some preventive therapy and your follow-up assessment is going to involve whether the stones got bigger or whether they increased in number, okay? Almost all the radiology reports that you're going to read, they'll say, oh, compared with, July 2017. And then they don't go on to tell you whether it was any change or not, okay? Even at my institution where we have excellent GU radiologists, I still have to remind them every once in a while, okay, if you're doing a comparison, can you please tell me if there's been any difference, okay? From your standpoint, you want to know how many stones the patient had and how big they are so that you can give appropriate guidance. If they have a very large stone burden, you may actually decide to refer them to urology for some preemptive discussions about preemptive therapy, okay? So this 35-year-old female nurse, recurrent stones, otherwise unremarkable past medical history, most likely stone type. Yeah, we should always guess calcium oxalate, but of course you can't tell it all from the history that I gave you because any of these types would be consistent, but in fact, these are the crystal types that we saw in her, and this is calcium oxalate dihydrate, this is calcium oxalate monohydrate. The type actually doesn't matter from a prevention standpoint, but diagnostically, the most common one you're likely to see are these ones. They look like X's, little square X's, and that's calcium oxalate. Okay, so her stone actually was calcium oxalate 95% and calcium phosphate 5%. Not uncommon at all to see what we'll call mixed stones, but the majority of the stone is calcium oxalate. So the question is, well, where's that phosphate coming from? So years ago, we used to think that the stones were kind of floating around, that uric acid was kind of acting as a nidus and the calcium oxalate was growing on top of that. And if you're as old as I am or older, you probably maybe even still think that, okay? But not correct, okay? Uric acid in the urine doesn't have anything to do, as best we can tell, with calcium oxalate stones. The vast majority of calcium oxalate stones grow attached to the tip of the papilla. And where they grow attached is usually this white stuff that is referred to as Randall's plaque, and that Randall's plaque is actually made out of calcium phosphate. So the vast majority of calcium oxalate stones are growing attached to the tip of the papilla with calcium phosphate. And most of the time, if you do see some calcium phosphate in there, and if they carefully analyze it, they'll say with an eccentric nidus, okay? Doesn't really change anything, but just remember that the calcium oxalate growing on top, the calcium phosphate. I should say we don't understand why Randall's plaques form. They probably form years to decades before the first stone forms. And as we start to learn a little bit more about what's causing that interstitial precipitation of calcium phosphate that eventually leads to Randall's plaque formation, we may be able to do primary prevention, but we're not ready there yet. But despite the fact not knowing that, we still don't know how to prevent recurrent calcium oxalate stones. Okay, so she got a CT report. You already heard me rant about bilateral, but she had a 3-millimeter stone at her left UVJ, ureterovesical junction, the place where the ureter goes into the bladder. You may remember from anatomy in medical school that it goes in at an angle such that it's very easy for stones to get stuck there. Remember, the ureter's kind of buried into the bladder muscle. Many times a patient will, particularly women, will be diagnosed as having a UTI and then be treated with antibiotics, doesn't get better, and it may be because there's a stone stuck at the UVJ. It gives the exact same symptoms as cystitis. So the question is, she's got a stone there, we know about it, what do we do about it? Okay, and so why do you need to know about this? Well, when a patient that has interacted with you before and develops renal colic, they're going to call you rather than the urologist. Do you know why? You answer the phone. That's right, okay? And that's the difference, okay? You can't take that stone out, okay, but you can provide the patient with some advice, and it's really important that you remember this, okay? So just because someone has pain doesn't mean they need it urgently out. I'm sure they want to, but we've gotten much better pain control, and actually non-steroidals are just as good, if not better, than narcotics for treating ureteral colic. As long as the pain can be controlled, then you can wait several days or longer. However, if there's an infection, that's an emergency, okay? And this is one of the few times that patients will actually die from a kidney stone if there's an infection proximal to the stone, okay? That's pus under pressure. They either need an emergent stent put in from below, ureteral stent, or sometimes they get a nephrostomy tube put in to try to relieve the pressure and then treat them with antibiotics. But it's not easy to diagnose an infection in someone with an acute stone, okay? So when someone has an acute stone, do they have white cells in their urine? Yes. Do they have red cells in their urine? Yes. Might their white count be a little elevated? Yes. So fever, does everybody get a fever with a urinary tract infection? Not always. So it's, in the old days we used to do gram stains. That's not happening so much anymore. But you may have to use your clinical judgment just to see how sick the patient looks, and that may be a reason to urgently get a urologist involved. Hydronephrosis, is that a reason to urgently remove a stone? The answer is no, okay? Hydronephrosis is a sign of obstruction, ureteral obstruction. Well, we know there's ureteral obstruction because there's a stone there. It may be complete obstruction, maybe partial obstruction, but just because there's hydro is not a reason for urgent intervention, okay? But if it's going on for weeks, then of course we want to do something, but if it's just for a short period of time, then hydronephrosis is not an indication. As far as how do we help the stones pass more quickly, well, there are some data that alpha blockers, Flomax is the one that, tamsulosin is the one that's most commonly used, but when those studies were done, it reduced the time to passage from several weeks to a few days less. Okay, it's not this idea that you give someone tamsulosin, all of a sudden the stone's just going to pop out. Okay, and as they've done more and more of these studies, it actually doesn't seem that it's helpful for small stones. It's only helpful for much larger stones, usually 6 millimeters or larger. Sometimes there will be a reason to acutely remove the stone, and almost always they'll do it cystoscopically. And with ureteroscopy, almost never do we do ESWL anymore acutely, and even for chronic management of stones, it's falling out of flavor. It's falling out of favor. The urologists actually love doing ESWL. There's great reimbursement for it, but it's actually not nearly as effective as ureteroscopy. Of course, ureteroscopy, you need anesthesia, but you're much more likely to make the patient stone free. Okay, so we're going back to Miss JB, and before she came to see me, these were the urine results. Total volume, both collections was less than my target of at least 2 liters. And I want to emphasize that I always get 2 collections, and that's because there's substantial day-to-day variability. Patients do not like doing 24-hour urines, okay? But if you only do 1, then you're going to miss a lot of things. I even showed you with that previous patient, the first one, who had completely two completely different urines, and if I had only gotten 1, I would have treated him very differently than if I had gotten the second. You always want to do 2. There's variability. You know, there's variability in blood pressure. There's variability in urine excretion. So her urine volume was, again, way lower than we wanted it to be. Urine calcium was on the higher side. Urine oxalate was mid-range. Again, her stone's calcium oxalate. Citrate was fine. And unfortunately, they didn't measure the sodium at the time. And I'll come back to sodium in a minute. So her main risk factor is low urine volume. Okay? So how much fluid are you going to prescribe? Okay, so lots of people say, well, you need to drink more. Okay, but we're nephrologists, so we're going to be a little more quantitative than that. So if I want somebody to make at least 2 liters of urine per day, and I know that this is her 24-hour urine volume, how much am I going to tell her to drink? So how good are we at assessing insensible loss? I mean, in the ICU with all those tubes and everything, we're still not good at measuring eyes and nose, right? We're just not great at that. So I don't tell people how much to drink. I tell them how much more I want them to drink. Because these values have already taken into account the water she's getting from other sources, from beverages, from food, how much she's drinking, but it also takes into account her insensible loss, okay? So in this case, I always pick the lower number, and I would tell her to drink at least 1 liter more per day, okay? I don't care if she's way over 2 liters per day, but I want to make sure that each day she's making at least 2 liters per day. So I'd ask her to drink at least 1 liter more, and that should put her over the top. A liter, for those of you still using the US, would be 4 8-ounce glasses. Okay, so I see her in follow-up. She tells me that she's drinking more. She repeats the 24-hour urine, and the urine volume didn't change. Where did the water go? She didn't drink it. You're very skeptical, aren't you? Yes. So, I mean, you could weigh her, you know, if she had heart failure, nephrotic syndrome, you know, what you're going to hear about during the course. Okay, maybe she's retaining the water. But if her weight hasn't changed and her urine volume doesn't go up, and she, for some reason, hasn't had increased in sensible loss from GI or skin, she's not drinking it. Who thinks she wants to get another kidney stone? Of course she doesn't want that. She's trying. If I told you you had to drink an extra liter every single day, do you think that you could do it? You know, maybe if you had the incentive of recently having a kidney stone, that might motivate you, but it's actually hard. So what's the main side effect of drinking more? Got to pee more, okay? I mean, so you drink an extra liter, she's going to probably be going to the bathroom 4 more times a day, okay? So the patients want to don't want to get a kidney stone, but if they can't drink more, okay, then you have to find other ways to try to reduce their stone risk, okay? And in her case, since she wasn't able to do it, even though her urine calcium wasn't sky high, her urine calcium concentration was high. And there's only two ways I can get the urine calcium concentration down: either reduce the urine calcium or increase the urine volume. If you can't get the urine volume up, then the other choice is to use a thiazide. I prefer chlorthalidone. I start with 25 milligrams per day in almost everybody, unless their blood pressure is very low. I use chlorthalidone rather than hydrochlorothiazide because it has a 24-hour duration of action as opposed to thiazides, which is only 6 hours. Okay. I told you before I was going to show you some data about that these variables are all continuous. Within our cohort studies, we've collected thousands of 24-hour urines, over 2,000 cases, over 1,000 controls. This is the relative risk of being a stone former. This is 24-hour urine calcium excretion. This is adjusted for all the other urinary factors because many of them are correlated. So not surprisingly, with increase in urine calcium excretion, the likelihood of being a stone former goes up. But there's no threshold at any QR. You see this little elbow here, and that's only because I collapsed all the higher values into 350. If we had extended the categories, this would have just kept going up, okay? So anything that we can do, and this is milligrams per day. If we change this to milligrams per liter, anything that we can do to put people down this curve will reduce their likelihood of new stone formation, okay? Traditionally, those definitions I told you before, for a woman, it was 250 milligrams per day, but you can see even at 250, there's already a higher risk than if you're at 100. For men, it's 300, already 3 times the risk. So even, quote, the normal range, there's already increased risk. So we want to push people down this curve. Okay, so what do we do for follow-up? So we want to repeat a 24-hour urine after whatever intervention you decide on, whether it's a medication or dietary changes or both. I usually wait at least 4 to 6 weeks because you want to get some sense whether the people are able to stay on it, not whether they can do it for a day or a week, but really long term. If the 24-hour urine suggests that they are still at high risk, then you adjust the medication, your recommendations further. And I will say that in follow-up, I only get a single 24-hour urine. I'd love to get 2, but it's just not practical. So you have to get some sense of the variability. And since the patients are going to be doing this over time, you will start to accumulate more and more 24-hour urines to give you a better sense of what their true values are. But after you adjust the recommendations, again, you want to ask the person to do another 24-hour urine just to make sure that what you're doing has made the difference. Follow-up imaging, the guidelines are all expert opinion, which is not particularly helpful. As I mentioned, I use ultrasound a lot, but ultrasound is definitely imperfect. Hopefully you have good ultrasonographers. If you have something for comparison, that'll help you. If someone had a procedure and a year later the ultrasound shows no stones, that doesn't mean they don't have any stones. It's unlikely they have a big stone, but not a small stone. If you're going to be making a treatment decision, you probably need to get a CT, okay? But you don't need to scan the whole abdomen if you're just trying to assess somebody's renal stone burden. So at our institution, finally, we're able to get renal limited low-dose CT without contrast, okay? So instead of scanning the whole abdomen, they just scan the kidneys by CT, and it dramatically reduces the amount of radiation that they're getting and actually provides very useful information. But I don't routinely get CTs, only if it's going to make a difference in my recommendations. Okay. Mr. L, 49-year-old accountant with Crohn's, had partial ileal resection in the past, recurrent intestinal obstruction, again, very common in patients with Crohn's, presented 6 months before he saw me with abdominal pain, and the question was, did he have intestinal obstruction? And so he did an exploratory laparotomy. So pre-op evaluation, he had 100 red cells in his urine. He underwent an appropriately indicated right hemicolectomy, and was doing fine until post-op day 5 when he had abdominal pain and they thought it may be due to tapering of his analgesics. Discharged home on Percocet, came 2 days later to the emergency room and found out a UVJ stone on CT, okay? He did need the colectomy, by the way, okay? This was just 2 bad luck things happening. Okay, patient with Crohn's disease, man, type of stone, and just remind you, I've already told you about uric acid, we've already discussed calcium oxalate, we've already discussed cysteine. Calcium oxalate, is that what you said? Okay, so calcium oxalate or uric acid are both possibilities, okay? In patients with inflammatory bowel disease, if you have high GI output, you actually lose a lot of alkali, so you can have a metabolic acidosis, which lead to lower urine pH, which would increase your risk of uric acid stones. These individuals also have malabsorption, so they often have high oxalate absorption from the GI tract, and so they're also at higher risk for calcium oxalate stones. So it turns out, so another reason really important to get the stone even in these patients, because most people, if you ask them what kind of stones with IBD, inflammatory bowel disease, they would say calcium oxalate, but it is possible for uric acid. You definitely want the stone type. Okay, so he had done these collections. Before he came to see me, urine volume was quite low, despite the fact drinking a lot, but he had very high GI output. His urine calcium actually was on the lower side. Again, not common in individuals with malabsorption, whether it's due to inflammatory bowel disease or other malabsorptive disorders. You'll now see patients with malabsorptive bariatric surgery that will also have very low urine calciums. But his urine oxalate was extremely high, okay? The average urine oxalate in a man like him is about 40, and his is more than twice that. So again, very high risk for calcium oxalate stone formation because of low volume, low oxalate, and his citrate is quite low. Again, the mean citrate for man would be about 700. His is extremely low, and again, citrate goes down when you have a systemic acidosis. So his urine volume's low. We'd already talked about this with the previous patient, so how much are you going to prescribe for him? Okay, so you might want to prescribe an extra liter to try to get above 2. What do you, even if he drank an extra liter per day, is it likely that his urine volume is going to go up by a liter? It may not, okay? And so in patients with malabsorption, you have to be really careful. If anything, I wouldn't start with a liter more per day. I would try to say, okay, drink 1 extra glass and see what happens to your urine volume and also your GI output. Sometimes it just all comes out in the GI output. So you have to be careful. And again, this may be another group of patients that increasing urine volume is not necessarily an option, and you may go to medication. As far as reducing oxalate, we want to put him on a low oxalate diet, but that alone isn't just sufficient. You want to make sure that these individuals have adequate dietary calcium intake. In many patients with or without Crohn's, they may be lactose intolerant. There are now options for dietary calcium that's lactose-free, but this may be one of those few situations where I would use supplemental calcium. I don't routinely recommend supplemental calcium, but if you are going to use supplemental calcium to bind oxalate, what else do you need to tell them about timing? With meals, okay? Remember, just like our calcium-based phosphate binders, you want to make sure they take it when they're consuming their phosphate. Same thing goes for these patients. Remember, many of these patients will eat small, frequent meals, so you may need to have them divide up the calcium into lower doses, but spread it out during the day. As far as citrate or potassium bicarbonate, either one you can try. Remember that potassium citrate are these wax-coated tablets, okay? And for almost everybody, whether you have IBD or not, if they consume them, they may see the pill fragments in the stool. But that's because our bodies don't digest wax. That doesn't mean they're not absorbing it. However, in individuals that may have malabsorption, if you give them wax, it may rapidly propagate through and they may not absorb it. So you may need to use something like potassium bicarbonate that's more readily absorbable. We need to talk about lemonade for a minute, okay? Years ago, there was a study in the Journal of Urology that gave this recipe of mixing lemon juice and water and other stuff, and this to raise urine citrate, okay? And this kind of exploded in the urology literature, but then somebody finally tried to replicate it and they couldn't, okay? But still, you'll hear the urologist saying, oh, throw some lemon in your water. And I'll say to people, if you like lemon in your water and it helps you drink, that's fine because it'll get you to drink more. But the amount of citrate that you're getting isn't a whole lot. There are differences in beverages, the amount of citrate containing. And so actually Brian Eisner, Mass General urologist there, actually measured the alkali content of different beverages, okay? And typically when we prescribe supplemental alkali, it's usually about 40 milliequivalents or 60 milliequivalents per day, okay? So that lemonade formula that I was just telling you about in Journal of Urology had about 6 milliequivalents per liter. So if I wanted to give somebody 40 milliequivalents per day, how much would they have to drink? Yeah, so if someone's drinking 7 liters per day, I don't care how much their citrate there is, okay? We don't have to worry about that. They're not going to be forming any stones. There are these other beverages, you know, if you could drink 4 liters of Diet Sunkissed Orange, maybe you'd like that, maybe you wouldn't. There are some other beverages. A Crystal Light actually has closer to 20 milliequivalents. If people like that, it's the lemonade version. But for most people, it's usually easier and more practical for them to actually take supplemental alkali. Okay, in the interest of time, I'm going to stop now. I'm sorry?
What about alkaline water?
Yeah, so let's talk about pH for a minute, okay? If you have the pH of, let's say 6, okay, or pH of 8, the amount of free protons or free hydroxyl groups in there is tiny, okay? Remember pH of 6 or 5 is 10 to the minus 5 free protons per liter. Okay, so when people say, oh, well, my urine's acidic because I'm drinking orange juice or I'm eating tomatoes, that's not the case, okay? It's endogenous acid production as well as foods that they're consuming that are either leading to alkali production or acid production.